I did.
Perfect. Okay. All right. All right.
All right. Well, good afternoon, everyone. Thanks so much for joining us for our second week of Grand Rounds. Glad to have you all here. And today it is my pleasure to introduce a lecturer who I had the privilege of learning from during my training and who is a celebrated member of our Division of Endocrinology. If you are not familiar with her, I guarantee you you're in for a treat today with today's lecture. And yeah, Dr. Villafuerte, in the summer of 2019, started practicing in Owensboro, Kentucky, so about 2 hours away from us, and still continues to treat us to these lectures. So without further ado, here's Dr. Betty Villafuerte. Her title today is Why Am I Gaining Weight Despite Eating Less? Lipedema, an Underdiagnosed Masquerading Disease of Obesity.
Thank you, Malika. Okay, so today I'm sure all of us always get this question from our patient. They keep on asking us on why am I gaining weight despite eating less? In a typical clinic day, I would get this question several times a day during the day. So since I have been investigating this problem, and doing more thorough physical examination on most of my patients who are complaining about weight gain, I have noticed that most of them have a condition called lipedema. So let me go to the next slide. Hopefully at the end of the lecture, you will understand how often we see lipedema and define the criteria and stages of lipedema. Understand the potential role of estrogen in the development of this condition, and discuss the treatment options available for managing this condition. Ooh, it's not moving.
Dr. V, just put your cursor inside your slide. There you go.
Okay.
Did it work?
Okay, I got it now.
Is it working okay now? Perfect.
Yes,
okay.
yes. Okay. This is a sample patient, okay? So this is a 36-year-old female who came in insisting to her primary care physician that she has hormonal abnormality. That's why she's gaining so much weight. As far as she can remember, she started gaining weight at 5 to 6 years old. By the time she was in 5th grade, she weighed 300 pounds. She recalled that she is always starving and has been eating a lot of ice cream and cakes. At 31 years old, that's 5 years ago, she weighed 340 pounds before pregnancy, and then she gained another 15 pounds during pregnancy, which she never lost. A year later, she was diagnosed as having stage 2 cervical cancer, so it's squamous cell carcinoma of the cervix, and she underwent surgery. She had a robotic radical hysterectomy with right salpingo-oophorectomy, left salpingectomy, so the left ovary was left behind. She had pelvic lymph node dissection of the sentinel lymph nodes. In addition, she received weekly cisplatin therapy, so she had her chemotherapy, and then radiation therapy in the pelvic area. By the time she finished her treatment, she now weighs 488 pounds and had BMI of 89.40. Since people tend to exaggerate their weight gain, I then went on and reviewed her medical record. 10 years ago, she weighed 320 pounds. 5 years ago, she weighed between 395 to 418 pounds, and now she weighed 473 to 488 pounds this year. On her family history, both of her parents weighed over 300 pounds. She said, the funny thing is my father had gastric bypass surgery and he barely lost 50 pounds. On the other hand, my cousin had gastric bypass surgery and lost almost 200 pounds. So she is reluctant to consider bariatric surgery because she saw what happened to her father. However, she had an elder brother who's over 6 foot and weighed 200 pounds, and a younger brother who's also over 6 foot in height, and he only weighs 150 pounds. His lab test, initial blood test, this is a random blood test around 11 a.m., showing ACTH that's low. Cortisol level was low. I have not done the 1 milligram overnight dexamethasone suppression test. Her LH and FSH are both elevated despite one of her ovary was left behind. But remember, she also had chemotherapy and radiation in the pelvic area. So her estradiol level was low. I checked her androgens because she's complaining about hirsutism at the same time, and she does not have hyperandrogenism. Her vitamin D level is low and her TSH level is low. This is how she looked, exactly how she looked. Her legs, and you have all these fat lumps, and she had this cut off area between the feet and the legs. It's called calf signs, calf, as if you have a calf here. So this is where all the fat accumulation occurs, and then the feet is not involved. So what is lipedema? Lipedema essentially is abnormal deposition of subcutaneous adipose tissue leading to bilateral disproportional volume increase of lower extremities and sometimes the arms also. The fat deposition typically does not involve the hands, the feet, or the trunk. It's highly underdiagnosed by healthcare provider. It's frequently misdiagnosed as obesity or lymphedema. It is 1 in 72,000 within the general population as reported by child. But there are other studies that show that 11 to 18% of postpubertal girls have lipedema. In a study in a lymphedema clinic between 2005 to 2012, Forner Cordero reported that actually 18.8% of the patients who showed up in a lymphedema in a lymphedema clinic actually have lipedema. In a study of professional women in Germany, they found that 39% of women have different stages of lipedema, and the prevalence in general population in Germany is 9.7%. It usually affects mostly women and usually starts in puberty. Sometimes it has been reported to the onset is following pregnancy or menopause. So it's usually associated with hormonal changes in estrogen level. In a small study, they showed that 6.5% of infants who were supposed to have the lymphedema actually suffered from lipedema. So again, it's abnormal subcutaneous adipose tissue accumulation, mostly in the lower extremities. So it's usually bilateral, mostly female. You hardly see it in male. In male, it can only occur in hypogonadal male and male with liver disease in which their estrogen level is elevated. So it's mostly female disease. It's usually bilateral and symmetrical, does not involve the hands and the feet. They have edema, but it's a non-pitting edema. If you push through the subcutaneous fat, it's tender. And the enlargement of the fat is not responsive to weight loss. It has negative stemmer sign because it's not lymphedema. There's hypothermia of the skin. You find telangiectasia, vascular fragility, and easy bruising. In some patients, they complain of pain on pressure and touch. They also complain of the feeling of heaviness and tension in the affected limbs. Only about 30% of patients have arm involvement. So arm involvement is not very common. Okay. It comes in different types, okay? These are very exaggerated pictures. Most patients do not present this way, okay? Type 1 is when the lipedema involved the hips and the buttocks area mainly. Type 2 is the distribution of fat accumulation occurs between the hips and the knee. Even the legs is not involved. Type 3 is when you have accumulation of fat between the hip and up to the leg area. And type 4 is if you have only upper extremity involvement. Type 5 is very uncommon. It's mostly the leg involvement without significant involvement of the thigh area or the hip area. So the types of lipedema is based on the distribution of fat accumulation. Then it comes in different stages. So, stage 1, if you look at this, okay, you would think that the patient is only slightly obese. But if you feel the fat in this area, you will notice that there are nodules. So, it's not a rubbery fat that you would normally observe with obese patients. Instead, it's fat nodules that you can feel. So a lot of my patients who come complaining of weight gain are actually on stage 1 and 2. Okay? Stage 2 is when you can visibly see it by just inspection. You can see that they have uneven corrugated skin surfaces. And if you feel the fat, it's going to be nodular again. And by this time, they have moderate to severe fibrosis in this area. This is stage 2. Stage 3 is when you have all these disfiguring fat deposits, okay? And these are actually very obvious when you see it. Again, there's a cuff sign, meaning there's a cut off between the fat accumulation. between the legs and the feet because the feet is not involved. You don't see this in lymphedema, this cut-off sign, okay? You have to look closely in stage 1 for the calf sign. I usually ask them to stand up for me to look at the calf sign. Again, stage 3 you can have all these folds and divots of deforming fat, okay? And stage 4 is when there is already, if you don't treat them under this condition or under this condition, what will happen is they will develop concurrent lymphedema. Now you have a situation by which you have lipoedema, meaning there's lipedema or fat accumulation. At the same time, you now have lymphedema because you did not treat it while they are in these stages. Okay. How to distinguish obesity from lipedema? It's always about body proportion. Most of obese women will have predominant fat accumulation in the abdominal area, the so-called apple shape, whereas with the lipedema, it's an exaggeration of the gynoid shape, or it's the hip, the thigh area that are involved. So if you ask the patient and ask them to, show you their whole body proportion, you can tell whether it's mainly obesity or mainly lipedema. Unfortunately, most of the time, lipedema patient will be also obese, so you end up with a combination of both. These are different studies showing how much of the patient have normal body weight, how many are overweight and obese. And you can see that about 3.3 to 20.4% of lipedema patients have normal body weight. 10 to 25% are overweight. And most of them are really obese. They have BMI of more than 30. So that consists of 50 to 86% of the patients with lipedema. So usually you'll end up with a combination of lipedema and obesity because it's very common. Now, it does not mean that if you're skinny, you cannot have lipedema. This is Alicia Key. So as you can see, she's not that obese, She's maybe a little overweight, but she has obvious lipedema. This is Misha, whatever her name is. She is skinny, and you can see that she has obvious lipedema. So, it does not only occur in overweight or obese people, but normal weight people can also develop this condition. In fact, it's one condition that most physicians miss most. These are two studies showing a group of patients in which the onset of the disease is at 20 years old, and then it took an average of 18.3 years before they were diagnosed at 38.3 years of age. So it's this group of patients in which the mean age was 16 years old in terms of onset of the disease, but they were not diagnosed until 31-year-old, an average of 31-year-old. So it took 15 years to diagnose the condition. Again, the most difficult part probably is to diagnose it when they are in stage 1 and 2. again, it's the proportion in comparison to the abdominal area. For example, this patient is not obese, and you can clearly see that she has stage 2 disease of lipedema. This one is obese, of course, and at the same time, you can see that the fat accumulation is disproportionate on her lower extremities, and you can see the bruises and also the, capillary, sometimes hematoma. You can see it here. Again, the key is a lot of patients who complain about weight gain despite going on a diet are normal weight, and they have really, it's hard to tell whether they have lipedema or not unless you feel the fat, okay? When they're at stage 3 to 4, it's easy to tell if they have concomitant obesity. Usually you get a double fat layer. This is very common. I see most of my lipedema patients have this extra layer of abdomen. Again, by the skin texture, that's how you stage the disease, but you have to feel for the fat nodules in order to make the diagnosis. The easiest one, of course, is to, by stage 3, it's very obvious that they have this problem. Again, it has to be distinguished between regular obesity and lymphedema. Obesity and lipedema are both bilateral and symmetrical. Again, you can, if you have obesity, you can see it from the face. The trunk is involved, whereas usually the trunk is not involved in lipedema. Sorry. The onset usually is after puberty for lipedema, and it does not occur in male. You see bruising, tenderness in lipedema, but not obesity. You don't see pitting edema in both conditions except with lymphedema. The skin consistency in obesity is normal, whereas if you feel these fat nodules in lipedema patient, it's very soft actually. And sometimes it's painful, but not all the time. So what is the cause of lipedema? The short answer is it's unknown. There are a lot of, hypotheses that it may be an estrogen-related issue, primarily because it happens in female only. It could be a blood vessels issue that lead to fat accumulation, or a primary adipocyte issue. There's something wrong with the proliferation of the adipocytes. The bottom line is you get hematoma and petechiae, you can get lymphedema and tissue fibrosis when it's advanced cases. And when you have all this high volume of fat, you have reduced mobility and pain. So in terms of genetics, positive family history has been reported in between 16% to 64% of the patients. Most of the time, it's around 50 to 60%. In a study of 330 family members, they found that it's possibly an autosomal dominant inheritance with incomplete penetrance, and it could be also X-linked dominant disease inherited. There are certain genes that has been defined to lead to lipedema, but these are case report mainly, one of which is PIT1. This is the gene that's involved in regulation of expression of growth hormone, prolactin, and TSH in the pituitary gland. In fact, it has been shown that people who had pituitary surgery because of microadenoma or macroadenoma has a higher incidence of lipedema. There are other genes like the androgen receptor transactivation and all of this that has been, it's all case report of lipedema. So these are all the other genes that has been reported associated with lipedema, but again, it's individual cases, so it has not much significance in terms of explaining the pathophysiology. It is thought that estrogen play an important part in development of lipedema, primarily because estrogen alpha has been shown to be in the POMC neurons, and that's the appetite center of the brain. And when you mutate or you delete the ER alpha expression in the brain, the rat will gain weight and start eating a lot more and had abnormal fat accumulation. Estrogen also play an important role in the transition of fat distribution in female from premenopausal gynoid distribution, meaning most of the fat are in the hips and in the femoral area, premenopause. Then after menopause, it becomes accumulated in the abdomen. Estrogen is involved in basal lipolysis of the adipose tissue, and it has been shown that if you infuse estrogen, what will happen is there will be increased lipolysis of the abdominal fat, but not the gluteal fat. And in fat tissue obtained from patients with lipedema, it has been shown that they have more estrogen alpha receptor than estrogen beta receptor. And the estrogen alpha receptor mediates most of the lipolytic action of estrogen. So, although there are, for example, people develop it during puberty when their estrogen level is going up. They also sometimes develop it when they go on birth control pill, when they get high estrogen level. However, when they go through menopause also, some people do develop lipedema after menopause, like the index patient I was showing today. There are theories also that maybe it's a vascular defect that leads to it, because the blood vessel has been shown to have all the stem cells of the adipose tissue. So there is also a lot of permeability issue. There's that's why they have increased vascularity in the adipose tissue. There's a lot of evidence for periarteritis or inflammatory cells around the adipose tissue. So that's another theory. Another theory is it's a primary defect of adipocyte growth, because when people get this fat from lipedema patients, there is a lot of stem cells for adipocyte formation. It's much, much higher than normal fat. So and most of the stem cells come from the perivascular area. So the hypothesis is maybe it's, there's a lot of growth factor for the stem cells to grow into mature adipocytes. In other words, it is not clear why people develop lipedema. So what are the treatment options at present? Okay. I usually give them educational material on lipedema, and I did not bring it here, but there's an article that will explain to the patient what lipedema and what treatment options do they have. I will send that reference later. So patient will understand what they have, and then advise them to start exercise therapy and obesity treatment, and then skin care and weight management. But the more specific treatment is, aside from exercise and skin therapy, is I sent them to physical therapists to do manual lymphatic drainage. But the physical therapist has to be familiar with how to do the manual lymphatic drainage, because I have several patients who then ended up in the ER because the physical therapist drained their fluids towards the lungs, towards the central area, and then they get very short of breath, go to the ER. I also ask them to get compression wear, so whichever part of their body has this lipedema, they get compression wear. And I have patients who recommended going to Solidia. That's a company that will do compression wear. Most of the time, I give them an intermittent pneumatic compression devices. I will show this, Of course, alleviation of pain, reduction of edema is another way to treat it, okay? And to increase their mobility and weight control. I have some recommendations on weight control. I got the data from Dr. Karen Herbs, who's a national expert on adipose tissue disorder. So she has a specific recommendation on how to eat for patients with lipedema. So essentially, once you assure them that their condition is a genetic problem, they cannot eat their way out of this weight gain, then aside from avoiding all the measures that can cause obesity, the patient feel more settled. I usually recommend a whole body vibration machine. So they can get this online, and it costs only $100 to $150 for this vibration machine. And there are hundreds of this vibration machine in Owensboro since I moved here. Okay. I also recommend exercise like walking, cycling, swimming, Pilates, or body vibration. Compression stockings, also intermittent pneumatic compression therapy, and it's recommended by the Lipedema Society that they should try horse chestnut or diosmin. So I don't have experience with this. So I usually send them this machine, okay? This is a company, Tactile Medical, that will go to the patient's home and start measuring the diameter of the legs. So all I do is to fill a paperwork that says what the insurance company of the patient is, etc., and send it to the company, and they'll do all the subsequent paperwork. I'm no longer involved with this. Okay. It's recommended after 6 months of conservative treatment, if it's not successful, if the patient still has lots of pain and there's a lot of psychological barrier to go through. In the German medical, I don't have a United States medical recommendation. If your BMI is less than 35 and you have lipedema, they will treat it with liposuction. If your BMI is more than 35, okay, you need to treat the obesity first before they can go for liposuction of lipedema. If their BMI is over 40, it's going to be treatment of obesity. They will not allow these patients to go for liposuction. It's a specific type of liposuction. It's called tumescence local anesthesia, or in which you actually infuse anesthetic agent into the fat and then disrupt it with a vibration machine and then suck up the fat. So it's not the dry liposuction that you would normally get if you want, cosmetic procedure. This is a specific type of liposuction for lipedema. Again, tumescent liposuction or laser-assisted lipolysis are the surgical option treatment for this. And as I said, it's a specific type of liposuction in which they will infiltrate the fat tissue with large volume of dilute local anesthesia. Once the tissue becomes swollen, they then put in a cannula to disrupt the fat, and then they will suck up the fat. You can remove as much as 9 to 10 liters of fat each session when you treat it. This type of technique will allow the lymphatic circulation to stay intact, because the biggest problem with liposuction of patients with lipedema is they can develop lymphocyl. Lymphocyl is disruption of the lymphatic circulation, and then you have a big blob of fluid in each part that you had done liposuction on. So this is called tumescent liposuction. So that will spare all the lymphatic circulation so that you don't get a lot of complications. These are two of my patients, okay, with this condition. This is obviously a stage 3 to 4 lipedema. In the first place, gastric bypass, all those obesity reducing surgery does not work much in this patient. She weighed 670 pounds before, had pancreatic duodenal switch. She went to San Francisco and looked at the surgeon who invented the procedure. Duodenal switch surgery. She went down to 400 some pounds, but at that time her belly was hanging up to half of her thigh area. So she had all this tumescent liposuction. She had multiple lipectomy and panniculectomy, and had multiple complications with lymphocyl, and she spent over $150,000 having all of this procedure done because it's not covered by insurance. But she's well off. She's I think she is CFO of a steel company. So she went through all of this procedure. She said she had over 20 surgeries to remove fat. And this is how she ended up, So it's a very tough condition to be on, but that's because at the stage 1 and 2, she was not treated. Whether you can prevent the progression, if you treat it at stage 2, whether you can prevent it from progressing to stage 3 and 4 is not clear, but early treatment is really indicated in this case. This is a school teacher. So she had the type in which the thigh and the hip area is involved, but not the leg area. Again, she had gastric sleeve surgery, lost some 80 pounds and regained 40 pounds within a few months, she said. Because she had difficulty conceiving, she spent over 100,000 having IVF. So she had 1 successful pregnancy and 3 miscarriages. And her reproductive endo is in Louisville. So finally, the reproductive endo said, you have to do something about your fat before we're going to proceed with another IVF, because we know you have spent over 100,000 already. So here she came and said, okay, you need to fix my obesity, which a gastric sleeve surgery did not do, So these are very tough problems when you allow it to progress to stage 3 to 4. I have many patients, young patients, who came in complaining about weight gain, and their BMI could be 25. Most of them are BMI of less than 25, and you can clearly see that they have lipedema. So, it is not clear whether lipedema should be best defined as a lipodystrophy or pathological adipogenesis or, abnormal fat cell formation, or primarily a blood vessel issue or a lymphatic issue. We don't know the primary cause of lipedema, but we know it's a genetic problem. It is estimated that the prevalence in overall female population is 10%. The cost to the patient is actually very high, as I gave you in that index cases. By the way, in one day's clinic, I ask every patient to to pull down their pants. It's at least 20 to 25% of my patients has lipedema. The disease is diagnosed on clinical grounds on the basis of pain, feeling of tension, increased tendency to form hematomas in the affected area. Usually, for me, the most useful diagnostic marker is you feel the fat and it's all lumpy, The treatment, conservative treatment, is directed towards decreasing the pressure, decreasing the tendency to form hematomas, and the sequelae of the disease. The sequelae of the disease can be severe. When you have so much fat in your lower extremities, a lot of them do form valgus osteoarthritis of the knee, and then they have difficulty walking. So, limb-sparing liposuction can be considered as permanently reducing fatty tissue mass. As you can see in one of my patients, she had over 20 procedures, and yet, which is not paid for by the insurance, and yet she looked the same. But she said it saves her from, being bedridden. She's able to walk and do her job, it's supposed to be a rare condition, but I don't think it's rare when it comes to endocrine clinic, when they come specifically because they're gaining weight. It must be differentiated from obesity and lymphedema, and it's hard to do that if you do not ask the patient to drop their pants and look at the configuration of their abdomen, hip, and thigh area. Again, the diagnosis is clinical, and really it's hard to tell how to treat them, but I usually get all the materials I got from Dr. Karen Herbs while she was running the adipose tissue clinic, rare adipose tissue clinic at the University of Arizona, and I send at least 5 of my patients to go to University of Arizona to see her while I was in Louisville. So surgical approach should be considered, and it should be a plastic surgeon who's familiar with tumescent liposuction. It's not the regular dry liposuction that will work. We have a plastic surgeon in Bowling Green who do tumescent liposuction. Again, most of it, aside from differentiating it from lymphedema and obesity, you have to think about the onset of weight gain, and you have to examine them. And you know that weight loss surgery and restrictive diet is not going to work in this patient. As I said, I give them materials and suggestion from Dr. Karen Herbs from University of Arizona. Essentially, the diet that is recommended is no processed food, no artificial coloring, no certain type of oil, and certain type of nuts, being Brazil nuts, etc., that she recommended, And it's very restrictive. I send them routinely to dietitian for 1,200 kilocalorie diet, and I ask the dietitian to give specific food for Monday to Sunday, so that the patient know exactly what to buy. Okay, so today's event code is 1282034. So if you have any question, I know this is a simple lecture. This is primarily to familiarize most of us with this condition. So I think we miss the diagnosis frequently because of our physical examination. And really, it causes a lot of emotional distress on the patients, Anybody with questions?
Thank you for that, Dr. Villafuerte. Looks like you might have one question in the chat box. So if you stop sharing your screen and look in there.
Okay, let me see. I stop sharing the screen. Do I go to the chat box area?
Yes.
Okay.
Perfect.
Genetic predisposition early in life, yes. So the most important thing is prevention. Once you identify that the patient has this tendency, you have to I told all my patients with stage 1 and 2, this is your future. I show them the picture of stage 3 and 4. If you do not follow very restrictive diet, you will end up with this. Okay, the second question is how about the use of GLP-1 drugs? It's about the only thing that worked for this patient. I can tell you that. I gave Mounjaro to everybody. I gave Ozempic to everybody. So I tried phentermine on many of these patients, nothing works. These are stage 1 to 2 patients. So they're not really, obese. A lot of them have BMI less than 27, 28, So all of these patients are coming, with that issue. Okay. Yes, the next question is, has this been connected to PPAR gamma signaling abnormality? Yes. There are of course, adipocyte differentiation by insulin is through PPAR gamma, and there are studies showing that the PPAR gamma signaling is normal, actually, Okay. As again, Munjaro, there's a next question is whether tirzepatide has been used in these cases. I have used it right and left. I have over 50 patients on Munjaro at present. I have over 200 patients on the Ozempic. Seems like, I don't have enough experience with Monjaro because it's a recent, addition. So, but, anybody on private insurance can get that prescription and pay $25 a month for Monjaro. The reason for that is none of the insurance cover it so far, except for Humana Medicare. So anybody with, private insurance can get Munjaro for $25 a month. So I just give it right and left, Okay. What's
But does it help?
ICD? Yes. I don't have enough experience because I just started using it 2 to 3 months ago. So they all have not come back yet. But they're all asking for increased dose, Even I usually give them sample for 2.5 milligram and send prescription for 5 milligram. After 1 month, they all call trying to get the 10 milligram already. So they don't even wait for, their next visit. They're all calling to have, okay. To have higher dose. It must work sometime, but I have a lot more success with Ozempic 2 milligram with this type of patients. What's ICD code 10 is Q32. I don't know anything about ICD code.
One of our fellows was asking how we should code for this, so I just provided the
You just write lipedema. It will come out. There's code for lipedema. If it's painful, I used to see a lot of Dercum's patient, and familial partial lipodystrophy, but you can put lipedema, it will come out, Okay.
I had one last.
I think GLP-1 is promising, but you can see that patient that I illustrated, these patients are so desperate. They will do anything. I have about 10 patients who went and see a plastic surgeon already, and I knew it after the fact. They already have all those chat. They can go to Facebook and learn about this condition. And about 10 of my patients has, went to see a plastic surgeon for their liposuction. They're just tired of dealing with it. And then they just said, I'll go ahead and have liposuction, but it costs a lot of money. The first patient I showed you, she said every time she had surgery, she'll pay $3,000 to $5,000 for a liposuction, and then she'll get complications. Whenever she gets complications, her insurance will pay for it. but not the primary procedure. So she had to keep on shelling out for the primary procedure, but she was hospitalized 4 or 5 times for complications that are all covered by insurance. So, maybe that's the way to do it, get complications and then you get free, procedure. But it's a very costly disease for many patients. And these are well educated. These are not, patients who are uneducated eat their way out into this stage of, obesity. These are well educated. One is a school teacher, one is a executive of a steel company. That's why she can afford all these costs, So it is, that's why I always warn my stage 1 to 2 patients once they have this. This is what you're looking at in the future if you do not do anything about it right now. Some of the stage 2 patients wants to have liposuction. I don't prevent it. Maybe that will prevent going to stage 3. There's no data to show that, whether it's an unrelenting progression to stage 3 is another issue. At stage 2, most people can live with it, but at stage 3, it's really very disfiguring. Okay. Okay, hyperlipidemia. The funny thing is, this condition is cardioprotective. Most of them have normal lipid level. They don't have hypertriglyceridemia. Their cardiovascular risk is lower than similarly obese patients. So, actually, all these fat are cardioprotective. Their hypertension rate is lower, cardiovascular event is lower, so it's in a way, subcutaneous fat versus visceral fat issue. So they have much less visceral fat. It's all subcutaneous. So they actually have cardioprotection effect, which is weird, really. Okay. Any other question? Wait. This. Okay. So the main lesson here to learn is start feeling for those fat, But, sometimes young people are reluctant when I tell them to drop their pants. They said, why? I said, because I'm going to examine your fat, Don't be reluctant. It's a routine physical examination. You're complaining about weight, so I need to know where the weight is accumulating, So some young people are reluctant, but most people, I said, can you drop your pants? They said, okay. Most people will not complain. But for male, physician, it may be a better idea to have a nurse or, a medical assistant with you when you're asking patients to drop their pants when they're coming here in for weight gain issues. So it's safer to do it that way. But, it's very common, when the kid come with their mother, it's very easy. I'll just ask the mother to drop their pants and show the kid where she's getting it from, And then, they fuss about the diet that they have to go to. So I keep on showing them stage 3. Look, you don't want to go to stage 3, But it's very, very common. I would think 25% of my patients who come in complaining of weight gain have lipedema, which really we're not, looking at for a long time, Okay. Okay, thank you for paying attention to my talk today. I hope, you will start looking at everybody's, legs and hip, you know. And again, the cough sign for stage 1 is very subtle, so you have to ask the patient to stand up, in order for you to see that line. It's fairly obvious when they stand up. Okay. All right. Thank you. Okay.
Much.
Bye.
Good
Oh,
afternoon.
have a good afternoon. Okay, bye.